all of these implants are used, but I'm not a paid consultant for any company. Okay, so you can feel free to ask me about the limitations of any system that's out there. What is biomechanics? It's the application of mechanical principles on living organisms. So if something heavier than air can fly, that's an example of biomechanics. Something heavier than water can actually flow through the Atlantic and swim across the currents, that's an example of biomechanics. What's the influence or benefit to mankind? Our knowledge about wound healing comes from biomechanics. So when we look at the continuous passive motion, if somebody has a fracture, we are now able to figure out how we can make the bones and ligaments heal differently. Because it's going to tie right into our implant treatment planning. About 40 years ago, if somebody had an accident, they went for skiing or got into a car accident, they broke all their bones. This is typically how you would find our patients confined in the bed. How long do you think these patients would be like this in cast, typically? 6 to 8 weeks. 6 to 8 weeks. Do you think in today's HMO world, anybody can stay 6 to 8 weeks in the hospital? No, they're actually walking the very next day. Does it mean that the advent of HMO changed the human species? No, it's just our knowledge of biomechanics got better. We now know how to make use of our function to our benefit. So that's how the concept of immediate load came into existence. Earlier when Panama talked about implantology, all the implants were submerged for about 3 months. The exam question would be, what would you do if you have implants in the anterior symphysis? It would be 3 months or less, you can load those implants. So when we look at the analogy of a car, the best days of a car, when is it? It's when it's in the showroom. The best days of an implant is when it's in the vial. Okay? The moment you start driving the car around, you're going to see all these cars are eventually going to end up right here. And the same thing is true of implants too. Okay, you're getting started with implants. You start to load them and you start to place the prosthesis. The clock starts ticking. It's a matter of time. How do you expect a 4 millimeter diameter implant made out of type 4 titanium to withstand 400 pounds of force every time the patient chews? And that's over 1 million cycles a year. And you're giving a 5-year guarantee or a 10-year warranty. That's 10 million cycles of loading on a 4 millimeter screw that is supporting a 10 millimeter crown with a 1.2 diameter screw that's holding the entire assembly. Can you imagine? Ask the spectacles, your glasses manufacturer. What warranty do they give you for your glasses? How many times you've changed it? How many times have you changed your glasses in a given? Yeah, all of you wearing glasses.
Twice. I just started.
How many you will see how many pairs of glasses you'll have to change.
No, but I have a lot of pets.
But people don't have a lot of teeth to keep shifting, right? So it says something, right? So when you chew, there is a load that's applied and the patients are asking, what's the warranty? My warranty is very simple, lifetime warranty, as long as they don't chew. Right? But it's not possible. Some implants fracture within 6 months. And I'm in the business now of taking out, I bought a screw removal kit, so I'm taking out implants all day long. The fractured implants, now you'll see after 10 years in function, they are fracturing. Okay, it may not be your implants. Which implants will you take out? Implants that you remove. What are the most common reasons why you take out implants? When you didn't place them. Right? So also, when you have bone loss, when do you decide when to take it out? The implants that you keep are the ones you place. If someone else's implant, oh, I think that implants come out. It's your own implant, we'll nurse this. Now we call it peri-implantitis. So we see how the interpretation is. There's always a problem in terms of how we manage failures. So this is all boiling down to biomechanics. Why biomechanics? Because surgical failures announces itself right away. The moment you place your implant, 2 weeks later, the patient's complaining of pain. Or 3 months later, you're trying to connect the healing abutment and the cover screw spins along with the implant, starts failing. What would you attribute those failures to? 3 reasons, but I'm submerging it. Infection could be. What else? Overheating. So there's an operator error, there's a patient error. What else? The implant could be contaminated. So when you buy these chip systems, imagine these implants are manufactured supposedly in a clean room environment. Those implants have to go through a machining process, and when it's machined, you should know what drills are being used to manufacture implants. It's carbide steel. Carbide steel is going to get impregnated on titanium. So if the titanium is not cleansed with acid and then blasted, you're going to have impurities of titanium inside. So just because something is sterile doesn't mean it's good. Sterility only means the biological contents have been removed, but the chemical impurities can still stay on the implant. Okay, so don't just believe sterility as a factor for implant success. Many of these companies have to have certain protocol to be able to clean. So you can attribute that to surgical failures.
So how do you verify that it's all the chemical impurities are gone?
Verified, so that's why you need to stick with the reputed system. If somebody's giving you implants for $70, something has to give. Something has to give, okay? So what can give? So you have quality, you have service, and you have price. If your quality is very good and your price is very good, service sucks. Right? So it's classical example is companies which have an online presence, like Implant Direct. Implant Direct has no service reps who can come into your practice. I mean, they don't have a nationwide service. So if the service is very good and the quality is very good, then price is going to be expensive. So examples are, you know, your Strawman, your Nobel, those are all expensive, not because the reps are paid high, it's because that's what it costs to maintain the company. So am I advocating that the more expensive the implants, it is better? Not really. Not really. But you maintain your protocol in your practice. You know how many failures you're getting and immediately notify the company of the failures. Don't keep quiet because the company needs to report to the FDA. And if you see a cluster in your practice, stop it, ship the entire product back to the company and tell them I'm having cluster failures. And I've had it. So that batches, you have no way of verifying it. Only the company can tell you, well, there was a contaminant associated with this implant. It's not that common, but it can still happen. Okay? The second failure is a sleeper. Nobody's really reported failures of sleepers. What are sleepers? Sleepers are integrated implants that you've not used. Okay? So it's an expensive ridge preserver, but nobody's reported failures of implants that are sleeping. The moment you place an abutment on an implant, the clock starts ticking. You begin the demise of an implant with the abutment going on top. So let's look at the implications of biomechanical failures. Screw fractures. I just spoke to you about those glasses. Those eyeglasses, after a while, those little screws will break. In fact, our prosthetic screws are tinier than the eyeglass screws. That's the weakest link. So if it's going to warp, you should know about screw mechanics. You should know about the torque values of every screw that you're using. My prosthetic screw should be 20 newtons. My titanium screw should be 30 newtons. And if it's titanium, the exam question would be, should the strength of the titanium screw be stronger than the actual body of the implant? Or should it be weaker? Weaker because these two fracture. Okay, so that's another reason why you want the screws fracturing rather than the implant fracturing. So there are different levels of fracture that's going on. Okay, so you will talk about screw loosening. So if the screw loosens, what should you do? What is the reason why a prosthesis is loose? Exam question will be screw loosening. So what would you do? Use a new screw or use the old screw?
You can get it out, use it.
Use the old screw. Okay? Why? Good. Because there's something called as embedment. A loose screw doesn't mean that you have to take the screw out. The loose screw is because of a misfit of the prosthesis. If you put a new screw, doesn't mean that it's going to get tighter. The screw that has actually settled in with your torque, that's called as preload. When you torque it at 30 newtons, you're going to set forth what's called as embedment. Embedment is the internal frictional fit of the abutment screw on the surface of the titanium, so it goes and welds itself like a cold weld. So there are surface irregularities of the screw that goes and mates into the surface of the implant. So when it comes loose, you want to use the same screw, it can go back and fit into that same irregularity rather than using your screw. Okay, so there is research behind it. If you want to know what article that is, I can show you. Yes?
Would you still use the old screw if you didn't torque it into place? If it was done by another dentist from another office?
Come again?
Would you still use the same old screw
Yeah.
if you didn't torque it into place?
Yes.
What
Yes.
what if they torqued it many times prior?
If they torque it at any time prior,
No,
then
many times. Like-
many times, you wouldn't know that, right?
Exactly.
Okay, so I will show you what article it would be in complications. Okay, so here. This is the article that you can support. Opinions regarding reuse or replacement of implant prosthesis, retaining screws. A systematic review. This is published in 2017, very recent. Conclusion, from the very limited available literature, it appears that retightening an occlusal screw or abutment screw is an acceptable procedure, as the evidence shows that retightened screws seem to remain tight. Replacement of screws as a routine procedure cannot be recommended. Okay, so this is what facts are. Yes?
You mentioned the screw strength should be weaker than the implant body. Should it be same for the abutment, weaker than the abutment?
No, depends on the type of screw. So if you're using a prosthetic screw, the prosthetic screw should be weaker. The abutment screw is generally made out of titanium alloy. So that's a trick question. When implants are made out of type 4 titanium, CP type 4, then the screw is always titanium alloy. All right, so in that case, the diameter of this screw is narrower, so it needs to be stronger than the actual implant. So what they imply is that in terms of the strength, it should be weaker, so it fractures.
For the prosthetics?
The prosthetic screw.
So like for the FP2, FP3 prosthetics?
You want the prosthetic screw to fracture.
And for a single tooth implant screw retain, you want screw to be stronger?
You depend, see, for example, let's say you are using 3i implant. The 3i implant is type 4 titanium. Hyacinth, Neobiotech, all these are type 4 titanium. The screw is what? Titanium alloy. All of the mini implants are titanium alloy. So for the sake of examination, just mention it should be weaker.
Because in your video you said
It said stronger. It's
Yeah.
stronger in terms of the material construction. If it is type 5 titanium for abutment screw, answer stronger. Type 4, it's weaker.
But if it doesn't mention the type
Then make it stronger.
Stronger.
Stronger. For the examination,
Stronger.
make it stronger.
What's strong?
For the screw itself, the abutment screw, not the prosthetic screw. The prosthetic screw should be weaker. Okay?
And there was one more question where if you put the implant at 35, 40 degree, would the abutment fracture or the screw fracture?
the abutment. If the abutment angulation is greater than 40, then the abutment will fracture, not the screw. Greater than 40. Okay.
What would be a reason to have the screw stronger?
Because the reason to make it stronger is because if it's sticking loaded, it'll keep fracturing. The only thing that's holding the prosthesis and the implant is what?
Screw,
Screw,
cold weld.
cold weld. So when it is stronger, it'll hold it better. If it is weaker, then it'll keep fracturing. So this question for abutment screw is only for hybrids. For a single tooth, you want it stronger. So those kind of ambiguous questions will be thrown out. So the questions that you'll be answering tomorrow will be about 150 questions. Okay? Out of the 150 questions, 75% of the questions will be repeats, or at least 60% will be repeats. There will be about 15 questions that are brand new, 15 questions that will not make any sense. So you'll all answer differently. So when the answers are all, some people write A, some will say B, those questions will be thrown out. That's part of psychometrics. So in essence, if you get 70 questions right, you'll pass. And I'll make sure you will have a 100% pass.
Yes.
Don't change the statistics. Okay? But don't answer on your, don't go rogue and answer on your own. Answer what this group.
Yeah, that's what I
Yeah. Stick to the consensus.
Kevin's gonna ruin the card. Kevin's gonna ruin the card here. That's the problem. He's been studying for 9 months.
No. You erase from your memory. Alternate control delete, whatever you've learned from the past.
So when are you giving us this magic?
And it's coming. When I keep talking about exam question, write it down. And I'll go over the paper still. So I'm giving you the rationale, so you don't get confused. So I don't want it to be a boring review. You need to be practical, right? So this is the reason why you have these kinds of screw fractures. So now you know why it needs to be what I say in terms of the fractures and the warpage. So a screw fracture, this question will have, this clinical problem will have 3 or 4 questions associated with it. So there are type 2, type 3 and type 4 titanium. CP stands for commercially pure. Okay? Type 2 is the weakest. Type 4 is strong. Type 5 is strongest. So what is type 5? Titanium alloy. So titanium alloy is Ti 6Al 4V. So 6 parts of aluminum, 4 parts of vanadium, that's titanium alloy. So what are the grades of titanium based on? It's based on the amount of impurities. The amount of impurities that are present in the titanium.
So it's only 1 part titanium?
Was it 90 parts of titanium? 6 parts. Ti 6Al 4V. So when you do Ti 6Al 4V, that's 90 parts of titanium, 6 parts of aluminum, 4 parts of vanadium. So that's the titanium alloy. The occlusal material fracture is about 68%. So why are all these fractures happening? So when you look at the evidence over a period of time, about 60% of your prosthetic cases will have complications. 60% over a period of time. So be ready. Success rate of implants is inversely proportional to the number of years you're in practice. Okay? So all this 98% you'll enjoy on day 1. Okay? Don't tell your patients about 95%. Because if they happen to be the other 5%, they will not care. So what you need to worry about is how you're going to manage complications. Just like you know how to place implants and restore them beautifully, you will now need to look at what you have to think about when these patients come back to you after 5 years.
Can you just briefly go over a very simplified approach of what to say, like what your protocol of like what they expect for the future, long term, and
Yeah,
also
yeah.
warranty and stuff like that. Like what is like just the quick spiel that you say about your you say single treatment.
I don't know if you remember my first lecture. Okay? I hold all three options on the same pedestal. Whether it's a removal, whether it's fixed or an implant, they all have the same level of sophistication. So if I'm doing a partial, the partial should look exactly like a missing tooth, like a replacement. So nobody should say, oh, you have a nice partial in your mouth, or a nice implant in your mouth, or a nice bridge in the mouth. That means everything failed. So I start off by saying all the options have the highest of predictability. Now we'll talk about the pros and cons. If you do a bridge, these are the pros and cons. If you do an implant, these are the pros and cons. I know your insurance company only has the bridge option, you don't have the implant option, but in your case, I think if I do it in this way, the probability of survival is higher with implants. That's it. So probability of survival is better because once you know what are the limitations, the patient is fully aware. Don't try to talk them into any treatment plan. The patient should say, I like it, I want it tomorrow. And that's going to be based upon how well you present the case. Right? So it's all about in how you're going to be talking to the patient. The patient, what's the benefit of case presentation? Helping patients want what they need. Right? People will not buy what they need. People want to buy, that's a want. So if I'm looking at the option here, I'm going to talk about what's possible, and it should not be based upon economics. Right? Treatment plan in general should not be based upon the thickness of the wallet. It should be based upon an assessment of the amount of disease that the patient presents with, so you can come up with a plan that is commensurate with the amount of disease the patient has. So it's completely justified. So if you tell them in advance, this is what it is, this is, I see the predictability. You've got periodontal disease on the opposite side. So if it's treated, the chances of the implant bone loss is going to be the same on the implant too. What do you want me to do? So don't take ownership for the patient's problems. Right? So once you have outlined every possible option, I don't know, do you still recall my first presentation? I gave you a whole checklist of what to look for. You look for bone level, abutment support, periodontal pathosis, endodontic problems, biometrical problems, cost, predictability. So I will line that up and then present the case. So when that adverse response happens, my doctor told me so. You told me that this might happen. So I would say, what you're really asking me, when the patients tell me or ask me, how much warranty can you give me? There is no warranty. Okay, what you're asking me is, worst case scenario, what's going to happen to me? Is all that they're asking for. Worst case scenario, if this fails, I will be able to resurrect and rehabilitate. We have measures of grafting. We can build the bone back and I will be able to replace it. And the option B would be, we can still do the implant, or do the 3-unit bridge, is what my response would be. So just because bone loss is there, we feel guilty, oh my patient, I did something wrong. Patient losing bone. If the physicians start feeling bad for the patients, they will not be alive today. Amount of osteoporosis that are out there. No orthopedic surgeon will have pity and mercy. Oh, sorry, you have bone loss. All they are doing is writing prescriptions out of prescriptions. So osteoporosis is 60% bone loss in the body. Yet the physicians, consider it normal. And we feel so bad, oh my God, if we extract the teeth, there's 70% bone loss. Patients don't feel that same problem. If the patient only associated the amount of oral bone loss, alveolar loss, to the systemic loss, they will freak out. Nobody will say no for treatment. Can you imagine if I took my tooth out and getting a 70% bone loss? That itself is a compelling reason to choose implants. So I'm looking at it from a biological perspective, I'm looking at it from a functional perspective, and then there's an aesthetic perspective. So putting this together, this is my case presentation. And if worst comes to worst, if it fails, you're going to have to rebuild, and that cost you're going to eat up. Okay. So when you look at this, you should be ready for a 60% failure or morbidity. I'm not saying implants will fail. Implants don't fail that often. The headache is the prosthesis. That's our biggest nightmare. The best days of the prosthesis is when you take an immediate post-op picture. That's it. Nobody will show me a 5-year post-op. All the beautiful cases, including mine, they're all immediate post-ops. Look at that single tooth implant after 5 years. The other tooth is going to go this way. There's going to be discoloration. There's going to be metal showing through. We don't want to even look at it. All right, so you must have the stomach to be able to look at your cases 5 years down the road and see what really is happening to our treatment plans. Okay? So these are the biomechanical factors we are going to be discussing today. Biomaterials, length of implants, diameter of the implants, configuration of implants, surface characteristics, how you prepare osteotomies, type of bone density. Should I leave my implant single, or should I leave it freestanding, or should I splint it? Should the implants be straight, or should it be angled? What about placing the implants in a straight line versus staggered? Prosthetic connections. Should I do an external hex, internal hex, conical connection, or tri-load? When can I do immediate load? What is the influence of cantilevers? Should I do cement retain or screw retain? That's always a big debate. And finally, occlusion. So you can see the scope of biomaterials and biomechanics. I'll try and cover as much as possible in the morning. So let's look at the modulus of elasticity as one of the factors. So you all know what modulus of elasticity means, right? Can somebody define modulus of elasticity? What does elasticity? It's an exam question. It is stress versus strain. Okay, stress is force per unit area divided by strain. Strain is the ratio of change in dimension divided by original dimension. And what does that give you? It gives you this formula, right? Force per unit area. What has this got to do with what we do in dentistry? Let's take 1 foot of a rubber band and 1 foot of stainless steel rod. Which is more elastic? What's that? Rubber band is what we normally are led to believe. Let's look at the formula. If 1 foot of, if 10 feet of rubber band is, or rather 10 pounds of force is applied to 1 foot of rubber band, it's going to stretch almost 10 feet. The modulus is 1. If the same 10 pounds of force is applied to 1 foot of steel, how much will it expand? Barely. So look at the modulus. The steel is more elastic. Okay, elasticity is defined as the stiffness of a material, not the flexibility of material. Example question. So there are 3 questions that can come from here. So this is what we call as modulus of elasticity is equal to stress divided by strain. Okay, strain. So what is stress? Stress is equal to modulus of elasticity multiplied by strain will give you stress. So let me get through this. This is the exam question. So MOE, modulus of elasticity, is stress divided by strain. So if they ask you what is stress, equals MOE multiplied by strain. So that's defined as the stiffness of a material. Well, it still doesn't justify why we should be worrying about this in implant dentistry. Okay, so this is the reason why we have to worry about it. Everything's got to do with wear. Exam question. What's the disadvantage of a gold bar? Using exactly. So you can see why the friction causes the wear, and what causes the wear? The amount of contact and the modulus of elasticity. That's why you see our patients come to you repeatedly for changing the attachment. Right? Sooner or later, why don't we use one-piece ball attachments? For the same reason. If you use a one-piece ball attachment in a mini implant, that is a disaster waiting to happen. Because after about 3 years, your patient's going to go in and out, in and out, in and out. The balls are going to wear off. It's going to become flat, and there will be no more attachments to hold it in place. That's why the patients complain it's no longer tight. It was tight when you first put it in, but now it's starting to loosen. So we don't use Halo clips anymore. and the wear of the bars. So what is another reason why the bars keep coming loose? Passivity of the bar. The bars need to be passive. Okay, if it's not passive, the patient will have pain, and screw loosening is often a complication of non-passive fit.
So what causes the wear on the ball? It's usually a nylon.
Nylon, right? It's nothing. Okay, you'll see why. It's a good question that you asked. Hold the thought till you understand the sequence of the wear. So this is a stress strain curve, which is the material that's closest to bone in terms of modulus of elasticity. Titanium, right? You see CP titanium? That's closest to bone. Then you have titanium alloy, chrome cobalt, aluminum oxide, which is now even stronger than aluminum oxide. Zirconium. Now can you imagine if you marry zirconia to bone? It's a completely different material. The mismatch is tremendous. So if you have this much of mismatch and you're trying to put two components together, something's going to give. Right? So you can see the flexion. You can see why ceramic chips off porcelain to metal. Why does ceramic chip off metal? It's different. Now you can see, because when you're trying to insert that crown, the metal is trying to expand. The ceramic is not expanding, it snaps. So that mismatch, if it happens in bone, imagine what might happen with the integration. So now you're seeing this more and more. Let's say you're doing a bonding, a class 5 composite, some cosmetic contouring, and the patient's completed with the filling. Now how do you ascertain the faithfulness of the margins? How do you know that you've finished the margins well? What do you use? How do you gauge the marginal fit of this composite? Explorer. Explorer is made out of what? Stainless steel, right? You take the stainless steel and you start exploring the composite. What happens? What do you see on the composite? Some scratches, correct? Scratches is black in color. Okay? What's wearing off? Is composite black in color? So what is wearing off? Stainless steel. Which is stronger, resin or steel? Is plastic or steel? Steel, right?
Nobody knows, like.
Have you wondered why? Have you?
It can't be simple, so we're overthinking. You can't ask that simple.
It's simple, right? Resin is, it's after all plastic, this GMA, otherwise we'd be using resin crowns all day long. Think about the filler. What's the filler? Quartz. Quartz is 10 times stronger than steel. So what you're seeing is not the wear of the resin. The quartz particles that you think you have finished well is actually sticking out of the composite. And when you use your Explorer, the quartz is bearing off the steel. And you would have seen this in zirconia crowns or Emax crowns. When you take an Explorer and remove the fit checker, you'll see black lines inside the crowns. If not, try it next time when you do an all ceramic restoration and you try to scratch the inside, it'll wear off. All right?
So does that mean it's not finished correctly?
No, it's because it's rough.
Well, the inside.
Microscopically. Inside. Yeah, we don't want to finish properly.
Yeah, because you want it to be rough, but
Rough.
the outside.
The outside will not scratch because it's smooth.
Yeah.
Right?
Ideally.
So that's a way to test it,
Yeah.
if you've finished it properly
To
or
your
not.
lab.
All right? So what is the benefit, or rather the implication in medicine or dentistry? You know how hips fail? They blame it on dentistry. Right? They always say, I want a medical clearance. Please put the patient on pre-medication. Every patient will carry a card. You must be pre-medicated. Tell me the reason why pre-medication is part of orthopedic procedures. If somebody has a hip replacement, they'll say pre-medicate. What's the implication? Have you thought through the process? Infection from where?
Oral bacteria.
Oral bacteria, that goes where?
Blood.
Into the system and then seeds itself where?
The implant.
On the implant. So does that mean you pre-medicate every patient who has a hybrid prosthesis? These patients have 6 implants. So technically you should pre-medicate those patients. How stupid, right? There's absolutely no reason to pre-medicate implants because they are thinking, oh, bacterial blood flow and it's going to go see. The problem is not the infection. The problem is fretting. And you'll see why. Yes.
Frankly, the whole pre-medication thing is ridiculous.
It is.
I have a friend that's an orthopedic surgeon. I had my knee replaced 3 years ago. He said, you do not need to pre-medicate. The chance of getting an infection in a joint from an oral bacteria is 1 in a billion.
Right.
The only reason why we pre-medicate now is if you have to go to court because somebody got an infection in a joint, the first thing the attorneys will say is, did you see your dentist in the last 6 months?
Right.
Yes. Did he pre-medicate you? No, he did not. It's the dentist's fault.
Yeah.
That is the only reason for
It's
pre-medication. It's
completely
ridiculous.
baseless. I'm giving you, I mean, if a single tooth implant patient comes to you, do you pre-medicate?
No.
The thought doesn't even occur to you, right? So the same, in fact, the oral implants
Yeah,
are
more-
coming out
yeah.
through the gingiva.
Exactly. Worse is
It's more prone to infection. Meanwhile, this is completely covered. Nothing is exposed. Yet we, feel like pre-medicating. The reason is not because of infection, the reason is this. 2 parts of that. Which part of what, you had a knee replacement?
Yeah, totally.
What was the total components? Was it a
Titanium,
titanium and?
the titanium something
And?
plastic.
Okay.
It's Teflon or something.
Okay. Now think through this. What did they change? The acetabulum cup was made out of what before? It was made out of ceramic. So ceramic was the cup and then the ball used to be of titanium. And after a few months, what happened? What is going to wear? Titanium is going to wear against ceramic. So the particles of titanium started leaching into the tissue. And they got black hips and black knees. Right? So watch out for that. So titanium in a bulk form is biocompatible. But titanium in a powder form, the body doesn't recognize it. So there's an antigen-antibody reaction against titanium particles, and that's how they get osteolysis of bone. So the particles of titanium start leaching into the bone, and they cause a reaction. That's why they made it into a nylon. Right? So earlier it used to be chrome cobalt, and that's even more dangerous. So now we are switching to titanium alloy, the Zimmer or a Stryker, and then the cup is always your nylon. So that's the reason why we're doing this. So now again, coming back into dentistry, what is the influence there? The influence is things like this. So people who had CEREC, they said, oh, I have a zirconia block. I can do everything in-house. I make the whole abutment in-house, and then let's use it. So they started using zirconia abutments that are made in-house. And what happened to that? That was another disaster. Because imagine taking the zirconia abutment and sticking it into titanium. What's going to wear? Titanium is going to wear. So the intimacy of fit that was there on day 1 is no longer there because there is micro movement. The micro movement causes the wear of the titanium. So once it's worn off, what's the next possible complication? Screw could fracture or the abutment could fracture. So you had tons of these abutments fracturing because patient wanted white teeth. So that gave birth to the tie base. So now everybody's talking about tie base. That's another disaster waiting to happen. Okay? So you'll see what will happen with these different types of failures. So you had zirconium inserts that went into the implant which caused a shear fracture. So don't ever recommend a zirconia insert going into the implant. So that either use a tie base or use a custom abutment and then you can fabricate a crown on top of it. So when we look at the wear of the titanium zirconia implant abutment interface, it's not so much of a health issue, it became a cosmetic issue. Patients started to have tattoo on their gingiva as a result of zirconia.
About gold.
About gold? So gold again is not so much the, good question, you asked about gold. See the gold, when would you use a gold abutment?
Oh, you're trying to kind of mask that tattoo.
You mean a gold coating, that's a titanium nitride coating.
Okay.
right? So that is still being used, but that you cannot do it on zirconia,
Yeah.
right? So we should still know about gold. Tell me more about gold. When would you use gold? It's still used.
For a bar,
Or can be milled in titanium. Let's say an implant is sticking out like this. To change the angle, you cannot do milled abutments. You have to stick to UCLA abutment. So UCLA has a gold base and a plastic sleeve. So when they cast it, the molten gold needs to go and catch the gold base. If there's mismatch, if you go to a cheap lab, the temperature will be different, the gold will fracture off. Okay, so if you're going to go with a gold UCLA, make sure that you go to a very high-end lab that does 51% gold for the casting. Right, so still there is room for UCLA abutments. You must know about UCLA abutments. I'll show you some cases where you cannot restore the case any other way.
Now, is there a problem with the zirconia screw-down crowns that are glued to the titanium base? Is there a problem there?
I'll give you how many times have you taken an X-ray after cementation of a crown? You don't know what's inside because the whole crown is opaque, right? So typically what a tie base looks like, this is your implant. The tie base is a small insert with a small thimble. And now they expect to have a huge zirconia core cemented onto this little thimble. So if I have to do something to it in terms of adjusting the contacts or add contacts, the whole thing will burn out. So they have to de-cement it, burn it, get the contacts added, and then re-glue it. It's not an easy fix. So this is the weakest link. This can fracture, especially when the crown is this high and you're looking at a tie base that is this small, because all tie bases come standard. That's a problem. So tell the laboratory, I have a very large crown. You got a molar that's 10 millimeters. This will work for a premolar. This will work for a lateral. But it's not going to work for a molar that's like 10 millimeters in diameter, 12 millimeters in height, and a little tie base. That's not going to work. And the patient is in crossbite. That is going to definitely fracture. Okay, so this is what you need to be designing the case with the laboratory when the case comes back. How do you? So now you tell them, I don't need a tie base, give me a custom contoured abutment where I have a robust titanium, and then we would do a zirconium crown on top of it and call it screwmentation. So you will take the custom abutment, cement it outside the mouth, and do screwmentation. So that would be the other option to manage it.
So screw-bendable.
Screwmentable. Yeah.
the tie base, can you not do screw retain?
Tie base is always screwed in.
Okay, still it will fracture.
Because it's only cemented. It's only Nobel only has it with friction fit. Nobel doesn't even have cement on it. So the fit is supposed to be so intimate, it's like a virtual cold weld. Most laboratories use Panavia to cement the zirconia tie base to the zirconia crown. Okay, so know your materials so you can instruct your laboratories in the event there's a problem that might surface. Okay.
So this abutment, we ask them for the tie base or for the lab?
So it depends on the case. It's depending on the case. If I see a case which is going to be, let's say, there's a single crown, okay? I'll tell you my reasons. So my default crown for anterior posterior is generally PFM. Okay, I'll tell you why it's PFM. This is the reason, because I've seen cases come to me after 10 years. Right? So here's a patient.
Number 9, I believe, is a
This is about 10 years in function. Now the patient is having a loose crown.
Abutment has come loose. The crown apparently has been cemented with tampon. So we will be attempting to remove the crown so we can separate the abutment from the crown and retorque the screw.
So I use a GC plier dipped in emery powder. So that's a loose crown.
There's movement. Do you have any discomfort? No. Okay?
Make sure it's not the implant
So
that's
here's
loose.
our GC plier, which is coated with emery powder. And we grab the crown, hold it tight. There's the removal of the crown from the abutment.
Try doing
as you
that
can
with
see.
a ceramic crown. That's foolproof. And the abutment, look at the design of the abutment.
So we will.
You can never do this with tie base. Right? You can never do this with any other all ceramic restoration. You have to cut it out. So in terms of predictability, I look at my abutment. That's a robust crown which has grooves, and you barely don't need any cement. All I do is very thin layer of Tembana, I place it, it doesn't come loose. So based upon the design, your principles of crown and bridge, retention form, resistance form, length of the abutment, anti-rotational features, don't make it round. Your stock abutments are all round. So I have them with facets. I have grooves on those abutments because these are all milled abutments, and then you can get this done. So if I
Torque the abutment.
look at it, so I'm going to go back. I'm not changing the screw. I'm using the same screw. For 10 years it's been like this. I'm going to use the same screw to torque it.
As maybe slightly inflamed.
So this is a, and I want you to see this. If I have a thick biotype like this, all ceramic is useless. Because why would you need an all ceramic restoration in a thick biotype? Right? And not that you shouldn't use it, I'm saying it's redundant. Once the gingiva is 2 millimeters thick, it will not matter what crown you use. As long as it's fairly decent and it has the strength capabilities. Okay. So look at the abutment design. We'll go through abutment design. This is my protocol for a single crown. I am in charge of designing this abutment interface. Because I don't have a milling machine, so I asked them to send me the design of the abutment. So the design of the abutment is sent to me by a JPEG. I'll tell them, well, it's not good, change it. I can change the contours and have them. So this height of the abutment is based upon my tissue contours. This flare is based upon my contact points. And this final crown is designed, so if you're a fan of zirconia, then you can use zirconia, but look at the design of the abutment. It is square, not round, and then look at the contour. This contour is designed by you. Don't leave it, you don't want a lollipop. You want it to emerge in such a way that you know when it fits, there's no black triangle, doesn't push too much on the tissue. It gives you the ideal emergence profile and gives you total control. There's no way any cement can go down. Why? Because I'm cementing this outside. Right? And make sure that this is all seen. Why do I cement? Because I can adjust my contacts, make sure. I'm treating it like a regular crown. How easy it is to treat a crown. So I put the screw in the abutment. I have this crown outside. I'm checking for contacts, checking for the emergence profile, taking an X-ray, removing the whole assembly, cementing it, and taking it back in the mouth. This way, everything's under control.
And using Teflon for
This is permanent cement.
this.
Yeah, this is definitive cement. You don't need, because with that, you're never going to have to, the temp part is when you're trying to take it out.
And what are you doing to block out your screw holes?
Block it, you see, it's pretty good. So I could use Kerr's A3 opaque. Kerr has an opaque for metal.
No, I mean when you're cementing it. What do you do to block out?
Oh, I actually coat the abutment, and when the excess comes out, you use a micro brush and remove it.
That's it.
That's it.
You
That's
coat
very
the,
good.
you just coat it, okay.
Yeah.
You use like-
And this is important. You see how this is? This is designed by you. Don't leave the laboratory. You know what they'll do? They will take this and do a crown, which is easy. And now they'll give you a crown, which comes out like this. That defeats the purpose of a platform switch. It defeats the purpose of emergence profile.
So what are you asking the lab to do? What do you?
I'll show you. I'll show you what I asked them to do. Okay? That's a good question. I'm going to show you my prescription.
do you have to drill this occlusal, or do you ask them to drill?
It's all come ready-made.
Yeah.
It's already milled. Nobody's drilling. Don't drill. It's all milled with the hole in the center. Okay? So, you asked me about what do I tell the laboratory. So this is what I tell the laboratory. Well, for a single crown, what's that?
And if you felt comfortable, you wouldn't get the custom milled, it's already cemented and you can, if you felt,
Yeah, if you want them to cement it, that's fine too. You can cement it, but then you gotta be very careful. Let's say if the timing is off, it won't go. You follow? The question is, have them cemented, no problem. But if the timing is slightly off, it won't fit. Here I can put the abutment in, even if the timing is off, I can adjust the contacts and send it back to the lab. I'm not wasting another impression. Then I do just a pickup impression and the laboratory just recontours it. So either way, I mean, do it a couple of ways and see if you're comfortable having the lab cemented.
what lab are you using now?
I use 3-4, Joe Pissarro in the city is one of my labs. I sometimes use Glidewell, and then I use another lab called QNS in Jersey. So this cost is about $350. Custom abutment and a crown. If you go sell it to Glidewell, it's about $399, so not much of a difference. I give them a lot of volume, so you can bring it down to $375, $350. That's a fair fee, right? Between
And
the
Glidewell's good, their quality is good?
their Glidewell's amazing. See, Glidewell will only give you back what you give them. If you give them good impressions, no tears, no pull, they'll give you a very good decent job. Nothing is touched by hand. Glidewell is probably one of the finest labs in the world. Yeah, their quality control, they have artificial intelligence which tells you what is the likelihood of a remake on this impression. And they'll tell you, this doctor is going to call us back.
And what about anterior? Do you feel comfortable with them with matching?
Anterior, no. I'm only talking about posteriors. Anteriors, I would not send to Glidewell. Anteriors are local lab.
Who do you use local?
Joe Pissarro. Yeah. So anteriors, don't play with other companies. Don't ship it. Shipping is only for functional restorations. Okay? So, in answer to your question, this is what I'm asking for. This looks like a fairly decent emergence, right? You look at this. Look at the contours. They purposely give you that. Why? Because you can have a crown which has an emergence profile like this. It doesn't look anything different, right? But if you have something like this, I'll tell you what might happen. Okay, so this is one of my earlier crowns which I did with the Atlantis. Okay, so I have a impression procedure taken. Okay, so open tray, corrected the angle. I failed to recognize the flare on these abutments. I tried the castings. I told you the biotype is thick. You don't see any abutment showing through. In 6 months, the abutment shows. So this is a fault of all the CAD/CAM abutments. So if you're using CAD/CAM, get their design so you can have your input. So this is what I meant by the flare. If the flare is there, you're going to get recession, because imagine it's going to push on the gingiva. The gingiva is now no longer in support, it will recede. If the implant is screw it in, you won't have this problem. But the implant is cementable. Let's say there are some cases where the implant is very, very close to facial. And on top of it, if you have this flare, you're going to get this recession. So I tell the laboratory to take the flare off. See what I did? I took the flare off. So from the protuberance on the facial, you now have no flare on the facial. So the crown can slide under the gingiva and will not blanch. Okay? So what's the benefit of doing something like this? So when I look at my cases that come back, this again, these labs are notorious to give you abutments like this. this is completely damaging. So you spend a lot of money buying an implant that's supposed to be platform switched. And what do? They give you a flare. Why? Because they want to support the crown. Who is designing this? A high school kid. Getting paid $12 an hour is designing your abutments. Because they learn anybody can learn ExoCAD, and it's like an assembly line. So this is what I sat and modified chair side. You see the difference? I now have embrasures, which means if I have embrasures, I have a good chance of growing my papilla inside like this. Otherwise, it will be stunted here. So that's all part of your ability to contour custom buttons. Yes?
If you modify chair side, then the crown won't fit the way it
No,
should.
it's only outside, right? It's only the contour. You're not modifying the connection. You have the crown. You modify the crown and the abutment together. So this is what I do. So I didn't show you the previous one. So I take my disc. So what I would do is I'll take the abutment. So when I get this back, I'm telling them, change it so I can modify any of these connections. So if I have this,
You need to do that?
look at this. I can take a cup-shaped disc and modify it with the crown. You see it?
Take it out.
You do that, I will guarantee you your aesthetic is going to be outstanding. And this is metal. And I'll show you how you can get good aesthetics with metal. So when I'm looking at the emergence profile, so this is what is changed in the new one. So now we got all this tissue to fill into that embrasure. And look at this. How ugly that is.
So on anterior teeth, you always ask for
A negative emergence profile.
negative.
Negative.
That's what it's called?
Okay, so even for posteriors, you can have good papillary fullness if you open it up. And this happens all the time. So if you look at the way the crowns will be modified, okay, so here's a patient who presents with number
Yeah, I thought
7. Number 7 is hopeless. So I'm having a single tooth implant here. This is a crown. Screw-retained PFM crown. This is the emergence profile of a PFM crown. 10 years later, the patient fractures this crown. So I have to make a new crown. So I take a new impression. This is an external hex. So I took a new impression. Now you can tell it's a PFM crown. The new crown is ugly. Look at my old crown. Doesn't show any metal at all. So it's all in the contours. So you take the crowns off, you can tell right away this crown as a positive architecture. The positive architecture will push the tissue and it will show what's underneath it. So I tell the laboratory, listen, you need to cut this back and make it concave. So now once it's concave, it goes in and you can't tell. Simple ways to modify your existing crown. Do this for your regular crowns too.
Why would the lab
They won't
automatically
know.
do that?
You think the gingiva stays in any of the models?
No, but wouldn't they, like,
They
would it
won't know
just be a
because-
better result?
All of our crowns, the implant crowns, where is the gingival moulage? Is it sitting on the model or is it in that blue box?
In the box.
The box.
From the model, you know, the country, always.
Always, but then when you put the crown in, it bounces,
You
right?
just change your lab if they don't do this. That's
Yep.
it.
But provided,
Done.
you make a custom abutment though. If the abutment's not custom, you give them what's the diameter of the impression coping? The diameter of the impression coping is only 5 millimeters. You're expecting a crown to be enlarged to 7 millimeters. So there's no way that with the 5 millimeter impression coping, they're going to come out with an emergence like that. So you have to have custom impression copings, yes.
The other problem is when they do their little tissue models,
Yeah,
and because I just had this problem, I had to send the crowns back because
What is
the
it?
contour was too overcome. They can push that rubber just moves and it doesn't blanch, so they don't know that, try pushing that crown down when you got three and a half
millimeters of
millimeters
tissue,
of
that should be
You
excruciating.
can't do it.
It's excruciating, yeah.
Oh, I numbed her up and I still couldn't get them down, so I had to send them back and they had to.
We got,
They
so
have
that's the
any
thing,
contour.
which we can do chair side, if you can mark it. So you mark the area and you contour it. So this is how you do it. Got a question?
I say, are you, after you make those modifications, are you polishing it right there, or are you?
Yeah.
Rubber
sending it
wheel,
back to polish?
rubber wheel, don't need to glaze it. No, rubber wheel. So when I get this, I'm gonna contour it, I can polish it and get it right back. So when this patient comes in, of course, the patient's gonna feel very upset because not only are they seeing the metal, there are two black triangles. Right, so what is the solution? The options are, you can do two composites on either side, have them overbuild it, or take this contact point higher up and make it look like a chiclet. Do neither of that. So you go back to your cup-shaped disc, take this down even more, and then don't give the mirror to the patient. Tell him to go home, put this in a Tembon, and in 3 weeks, you're going to see the film.
That's
With no
only,
modification.
that's only if the bone is supporting it.
You place the implant, right?
Yeah.
Then it should be bone.
But I'm saying, what if you get some bone loss? And
That's a different scenario. Then you're looking at modifying it with connective tissue mat. We will address that too.
And you're not.
So I'm talking about simple prosthetic modifications to give you aesthetics. If you're looking at a surgical correction, then you do soft tissue aesthetics. That I'll talk about next time.
And you're not nervous to thin out the porcelain too much that it'll.
That's why I use PFM. If you thin out on zirconia, it'll fracture. I can go to 0.5 millimeters with my metal. I can even leave a metal margin. Because as I told you, it's sinking in. So every time you see how the tissue is being held, that's what causes it. So let's say this is prosthetic modification. What about, okay, let me finish the reason why you should be doing custom impression copings. Right, so for a single tooth, this is basic aesthetic modification. So how do you get aesthetics for a single tooth implant? Diameter of the implant, space between the implant and the crown, and this is not even platform switched. Okay? So stage 2. If I have good thickness, then I can do half a tissue punch. If this is going to be like this, then I will do an incision like this and push it out. That's why I like stage 2. I like to bury all my implants. In the aesthetic zone, no healing abutments, no temporization if there is recession. Okay? And then I'm going to always go from the palate to raise my flap. Okay? And then make a provisional. And this is what you can do. So when I'm looking at a single tooth with a platform match design, use a thin, long implant, make a provisional, contour it in such a way that it's negative. Whenever you have negative contours, you got positive tissue. Always important, yes.
What are you temporizing with before your stage 2 surgery?
I'll show you a video on that. Okay. Alright, so I'm just going through the prosthetic protocol. So when I take my impressions, let's say you just take an impression like this. Your soft tissue model is going to look like this. How do you expect the laboratory to give you a triangular tooth when the opening is like this? See, this is a healing abutment. That's why I don't put healing abutments. Your shape of your tooth should be triangular, right? You want a profile like this. If you have something like this, your crown is going to look like this. All right, that's our problem. We don't want to have a crown with a ridge lap. That's the kind of crown you'll have. if you have a small healing abutment. Can you picture that? The tissue is inside, the tooth's got to be here. How are you going to connect it? So if you just have a healing abutment, you're telling the laboratory make it in line with the adjacent teeth. When they make it in line with the adjacent teeth, they need to have a ridge lab. Or you need to take the implant higher, place a provisional that's going to give you the contour, and then you will get your aesthetics. So till such time, these cases, you need to nurture them with a provisional. And I'll show you how to make a provisional for an immediate placement and a stage 2. Yes?
What is Morse taper?
Morse taper is the type of connection. Morse taper is a 3-degree taper of the abutment into the implant, so it creates a conical seal. It's got nothing to do with aesthetics. It's purely for retention. It is a form of connection so that the seal can be tight. Morse taper will not work in a bridge. Morse taper can only work for single tooth implants. Okay, so that's why I said, know about your connections before using them for all the clinical situations. Okay? So you don't want this. So how do you correct this? So now you have to look for soft tissue corrective procedures. You cannot do this with just prosthetics alone. And you can see all of these problems with all of these ridge labs.
When you say Morse taper won't work with the bridge, are you saying if it's screwy tape?
Yeah, you cannot do a screwy tape with a deep Morse connection.
But you could if it was symmetry tape.
Yeah. Yeah. So you keep them individual
Yeah, yeah.
and do symmetry tape. So this is what you will get. So now I'm getting and developing a soft tissue profile because I have the provisional, all right, and then we will take the provisional to contour my sulcus. Once the sulcus is contoured, your final restoration will mimic exactly like what it was there on the adjacent. All right, so this is the essence of your laboratory relationship with your chairside abilities to fabricate a provisional. Okay, so this is what you should be focusing on. And how do you capture the emergence profile? You spent a lot of time creating the sulcus. Now how do I transfer this information to the lab? Because sometimes the scan body cannot go subgingival. Right? You're still in the analog stage. So we will take a impression core. We will take the temporary abutment that was in the patient's mouth, attach the provisional, and sink it into blue mousse. And then you'll be able to fill this temporary with GC pattern resin, and you'll take it into the patient's mouth, and then you can create that profile. Okay. So you asked about the provisional. How do you fabricate a provisional?
Are you scanning all your implants?
I'm not. My scanning is only limited to single crowns, and only for posteriors. The anteriors, I'm doing it this way.
You do a Glibo scan body, the one that they own, the one.
No, I use Merit. So that's only, they're able to receive all of this. I'm not using the IO yet. I think Dr. Patel must have spoken about the IO. Yes?
If you're scanning the implants, do you still have to can you avoid transferring the soft tissue?
Yeah, you can scan, you can send the whole scan, because the problem with the scan in cases like this, the tissue will start to collapse. And if there's blood, forget it, you can't do it. So your provision has to be immaculate for the scan body to work. So if you remove, anytime you remove a healing abutment, should it bleed or not bleed?
Yeah.
No.
Well, some of you say it's bleed,
It should.
should not, should. Okay, think about the wound healing sequence. When I make an incision and I reflect the flap, I have titanium, which is biocompatible, and I'll have a seal. So what is the cell layer that's surrounding the healing abutment? Is it keratinized tissue or non-keratinized tissue? Or is it a junctional epithelium or pseudo-hemidesmosomal attachment? Or is it a fibrous tissue attachment?
It's like soft seal, right?
Pseudo-hemidesmosomal attachment. So you are, at what levels are the attachments going to be? At the very top, will it be keratinized? Can you probe a healing abutment? You just now said pseudo-hemidesmosomal. Will it be probable?
Yes.
technically you should not be able to probe. Because if you're creating a seal, that titanium, which is biocompatible, actually has these adhesions. All the blood clot will become a pseudo hemidisposal attachment. The very first time when you remove the healing abutment, it will bleed. That's a good marker of attachment. Now you try the impression coping, you come back a second time, you put the healing abutment back in. Second time when you remove the healing abutment, will it bleed or not bleed? It will be less or probably not. Because the number of times you take the healing abutment out, it will become a circular epithelium. Now when you probe, you can actually probe down to the floor. So that is the biology on a seal. That's why companies are now calling one abutment one time. You put the, at stage 2, I have my final abutment in place, so I can get the seal and not have to worry about any sulcus. Yes?
If a patient comes to you with an abutment that was put in by another dentist and they lost their crown a long time ago,
Yeah.
for whatever reason, and now the gingiva has grown
Grown.
over, especially that lip, right? Do you still restore that
No,
crown
you got to take that
above-
abutment out. You don't take abutment level impressions at all. So don't take impressions of that abutment. Always go for fixture level impressions. Because that abutment's margin cannot be discerned in an impression. Right? So they will not have, and it will be a small thimble inside. So when they remove the impression, it will fracture. Right? That little abutment is not going to stay. So I would not take abutment level impressions at all, in general. Okay? So you learned about abutment designs. Now I want to show you making provisionals.
So sequential times of removing healing abutments after the first time, it should not bleed.
Yeah.
And if it does,
Then you can go back. There are actually tissue revision trephines available. BioHorizon has a tissue revision trephines. You place the rasp, or it almost looks like a mill on the tip. So you place it in the center of the implant and you go like this. It's not a tissue punch. It has blades and cutting edges, which looks like the healing abutment. It will go and core out the center. And then you can place your abutment. Look it up.
what I mean is, if the second time you take out a healing abutment, you bleed, or the third time,
You will not
does that
bleed at all.
Does that signify anything that it continually
Then,
bleeds?
then it's inflammation. Then the patient's plaque control is not good.
Okay.
Okay, so for those of you who wanted to quickly review my provisional protocol,
Hey, Doc, what do you call it, biohorizons, a tissue what?
I think it's almost like a tissue mill.
A tissue mill.
So here's our extraction. I have a root that's in situ. The patient wants to have an immediate implant with a restoration. Okay, so the type of flap design. Should I go envelope? Should I go vertical release? Should I do a semilunar? What kind of incision design should I use here? So the incision design is going to be based on a lot of factors. So the incision design for access, the goal is to get to the root. So you need good reflection, aesthetics, tissue biotype, extent of the lesion, okay, ability to get primary control, primary closure. So those are all the factors that govern the type of incision you want to do. So here in this case, because of the loss of facial plate, I'm going to go envelope. So envelope design, no vertical release. Remove the granuloma. Okay, I'm using a luxator to remove the root. Measure the length of the root, the diameter of the root. Remove all the granulomatous lesion. Okay, so I'm placing my osteotomy. So the last osteotomy is being performed at 25 RPM. after you reflect, I have my implant inserted. Okay, implant's in. Now I'm having a prefabricated abutment that's being placed at the same time. So what are the factors that makes immediate load work? Name the 6 factors that you can consider an implant for immediate load.
Stability,
How much stability?
35 newtons.
Minimum. 35 newtons. What is the correlation of ISQ and stability? How do you gauge that 35 newtons? When your machine is there, you set it at 35 and the implant should go and stop beep at 35. So I would say go to 50. Okay, 50 is better than 35. So because 35 is the lower number, if you have 35 with a 10 millimeter implant, that implant's going to fail. 35 newtons with a 15 millimeter implant has a higher survival. So don't just go by torque values. The torque values need to be correlated with the length of the implant, the diameter of the implant, whether the depth of the implant is going to be 2 millimeters below the CEJ, the diameter of the implant is going to be about the width 30% from the apex. Okay? The angulation not to exceed the facial contours of the adjacent tooth. Right? So if you are able to satisfy all those requirements, then you can consider immediate function. If you're not getting one of these, just close the implant. Okay? Let's say you're not able to get length. The floor of the nose is lower.
They say about the pressure necrosis, if you torque
Pressure
it
up
too
to
much,
70, there's no problem, but the exam question will say, what is the pressure necrosis due to? Is at the time of implant placement. The torquing it at the time of implant placement. The diameter is 30% from the apex of the tooth. So I will show you how it is measured. Okay? So you have the temporary abutment placed. So here's my polycarbonate crown. Okay, so this is chair side. It will extrude. So the flap is still open. Remove the excess. Grossly trim it.
If the bone level is say 4 millimeters below the CJ of the adjacent tooth, would you place the implant at the crest? or would
Equicrest.
you
No,
would,
then equicrest.
you would do it at the
Yeah.
crest?
No, don't stick it even more.
And then would you pack tons of bone to try to build it up, or would you?
The right way is to pack the bone first, do a site development, and then place the implant. Always do it as 2-stage. I'll do a block graft first, then come back and do it.
What do you use to trim your post?
Carbide. Carbide. I do it not in the mouth. You put an analog and you use carbide. Titanium is soft. It will cut very quickly. So powder liquid with the knead-on technique. And you can use flowable, but I like this because it's easier to trim. Okay, so now I'm going to show you how to trim the margins. You talked about a negative profile. That's a negative profile. You see how it doesn't stick out? It comes out straight and comes out like that. Okay. So when we polish the necks, you'll see the importance of the CEJ. Look at all the tissue, it's really inflamed. Right? So I'm using a rubber wheel to polish it. So what this does, it mimics what's there on number 9. There's a reason why this concavity is there on number 9, that's the CEJ. So your provisional also should look like that. Otherwise the laboratory, if you send it for a digital lab, they will take this all the way up there with the same contour. And then you'll get reception. So digital technology cannot reproduce this. This is still hand scale. Right? So don't rely entirely on digital. You've got to use some of your anatomical knowledge to be able to transfer this. So you'll see the benefit of doing this. Once you get this in, we're going to close this up. And the advantage of doing something like this, you will create a nice sulcus. So when we have your impression coping with the resin, check your shade. This is the soft tissue moulage that stays in. Okay, so in spite of giving the lab all of this information, the crown is still over contoured. So I'm making a pencil mark. What does that pencil mark represent? The gingival contour. So from there on, it should be concave. So I'm taking my cup-shaped disc and taking away that contour. So these things at the time of insertion and try-in is what you should be looking at. No matter who is making it, could be the best laboratory, they will not be able to reproduce this. I do this even for my regular crowns. Anterior crowns, I always thin it down. Yes?
Mission 5 factors.
Length of the implant, diameter of the implant, stability of the implant, okay? Distance from the CEJ. Okay? And then finally, it should be 1.5 to 2 millimeters from the adjacent teeth.
This was a question, but central incisor, how far it should reach? And the answer was 5.
Oh, that's for the papilla.
Okay.
5 millimeters from the contact points.
How much length do you need?
Length should be at least 3 millimeters beyond the apex. 3 to 4 millimeters beyond the apices of the tooth that's being extracted. Okay? So if your factors are not satisfied, then just do it as a 2-stage.
But it's 2 millimeter from the CEJ of which we replace.
Yes, you got to.
What's some cases where we see that the adjacent teeth also have like a recession?
Then aesthetic parameters are not there.
Not there. So
Then you go with the bone, equicrest of the bone.
Equicrest.
So, there was one more question you guys wanted to know. Okay, you want to take a short 5-minute break?
Yes.
Okay, take a quick break, come right back. We will discuss biomechanics. Torque value, did you add the torque values too?
Brother, how you doing?
I will go.
You said, originally you said there's 6 factors for ingredients.
Hey,
I noticed that we had